liver, starting with the left lobe. And we're just going to talk about landmarks and technique. So you're going to start midline. Make sure you have that towel tucked good enough up there because you may have to really be scooping like up under their sternum. So we're going to do there we go. Okay. So everybody can see her liver on the screen?
Yes.
Alright. So we want enough depth so when we come over and get this part here that we're not cutting it off. Okay? So once we get everything adjusted, we don't want to be like that. Biggest thing about the liver is we want to see all of those margins. There's a lot of pathologies that can be hanging out right on the borders of the liver. So we want to be sure that every image we take, we're showing all of those margins. Deep breath and hold it. You have to have your patient take a deep breath. That's the only way you're going to see all of the liver. So I'm not sliding over, I'm staying midline, and I'm just angling like a fan, and I'm fanning all the way out. We scan all the way through the organ to make sure we see every bit of it. And then we're going to come back to our lateral view, which is going to be that pizza slice view without any vasculature. Our pizza slice is a little wonky, but they all are going to look more or less just like a triangle, okay? So again, I'm looking at all of these margins of it. So I went all the way through the organ and came back to it for this view. No blood vessels in there, okay? So that's going to be your lateral view. And your mid view is going to be with the aorta posterior. Now, keep in mind when we're doing these different organs now that you're getting to, you're responsible for everything in your picture. So we're not taking a picture of the aorta specifically, but if that's going to be a landmark to show me mid, show me that I can see the aorta and identify it clearly. Does that make sense?
Yes.
Okay, deep breath and hold it. So now I've gone from my lateral and I'm just fanning back towards midline. So we're starting to see blood vessels coming in and there's her aorta. So what I'm going to do is this right here. Breathe. Does everybody see what I did?
Yes.
Okay, so I cleared this for the most part. We can do a little bit more. But I'm not doing this. Do we see the difference?
Yes.
That's what we're going to say. Something's burning.
Oh.
Something smells burnt. You cooked your liver. It's overdone. This is well done. We don't like it. So keep your TGCs on enough of a gradient to where I can see what the actual echo texture of that liver is. But I've also been responsible for that aorta in my image. This is what that should look like, okay? Borders all around. That's my landmark.
And some of you skinny ones, like I know when we were skinning Saray the other day, her left lobe is so superficial just because she doesn't have a lot of body fat that we have to build pictures. So how like that border is
Appreciate
kind of cut off right there. If that was like that, then you would need to build your picture.
And that would just be like if say her whole liver covered this whole part of the screen and I could not fit that edge on, but I could fit the tip of it here, I would take that picture and then I would rock it the other way and show that border. So represent both of those margins if it goes all the way off your sector. Deep breath. So your medial is your caudate lobe. Okay, so that's mid. Now I'm just fanning back to medial. So this is, breathe. That's her caudate lobe right here. Does everybody see that?
Yes.
Okay, this is her full caudate lobe. So this image you would label caudate lobe, okay? Because that's what we're seeing all of. Deep breath. That's gonna be my medial picture because I'm seeing caudate and then IVC, right? As soon as I cross over that IVC, I'm in the right lobe now. So don't go too far. Keep that IVC right there. But this one, breathe. This is medial left lobe, but this is not a good representation of the caudate lobe. You can see the caudate is there, that's your landmark to know that you're medial, but those can be two separate pictures, okay? So because it says I want you to label the caudate lobe, show me a good image of that. Deep breath. So for me, I would take this one, label that caudate, and then this is going to be representative of that medial left lobe before you get into the right, okay? If you can see their full caudate and that IVC like this, that works too. You can label it Caudate, take it, take the label off, medial left lobe, take it. We agree? Okay. So, does that make sense to everybody?
Yes.
Got it. Alright, now we're gonna do, anybody have any questions on long so far? Are we good on that? Yes? Require words. Words. Okay, so the transverse, deep breath and hold it. You're gonna stay right in that exact same spot, and you're gonna just push up all the way out. That's her heart. So we're gonna go all the way past that. We're in the thoracic cavity now, so we're gonna come back down into this part. Breathe. Alright, so do you see how I kind of brought that edge in? At first it wasn't super clear, so it's a little bit of a slight twisting motion to bring all of those margins into my view. So there's no blood vessels here. I see a little bit of heart, which tells me you're very superior in that image. Okay? So that would be superior trans left lobe. Deep breath. So if I'd have had it like this, do you see how that's incorrect?
Mm-hmm.
Okay, we need to be here, showing me all of those margins. If I'm here, this is right lobe. We're gonna be taking pictures of that later. I don't care about that. Show me left lobe. This is gonna be one of your landmarks, your hepatic vessels. So anything coming off the IBC that way, breathe, is gonna be your right lobe images. So keep it here and over is what you're focusing on for left lobe, okay? These are the portal veins. They're more echogenic walls and they travel in perpendicular direction to the hepatic vessels. So that's your recumbent H is made up of the portal veins. Deep breath. Now everybody's recumbent H is not gonna look exactly like an H, but more or less, that is it. Breathe. So it's made up of the portal vessels going this way and this way, so it looks like an H that kind of fell on its side. Does everybody see that? So it might look like a little wonky sideways H, but more or less your recumbent H is your portal vessels in the left lobe, okay? And that's a mid landmark as well. Deep breath. So you're gonna come all the way up through, take your superior picture. Those are the hepatics here. And right past that will be your portals for your mid image. And then fanning even more inferior, I need you to decrease your depth, okay? And show me, breathe, posterior. Oh, I'm sorry, inferior trans. The pancreas is gonna be your landmark for the inferior transverse, okay? This slightly more echogenic tissue to the liver is gonna be your pancreas. Do you see how those textures are different?
Mm-hmm.
Okay, so this, a healthy pancreas, is gonna be a bit more echogenic than your liver. This is gonna be a portosplenic confluence, so that tells me this is the head of the pancreas, inferior to the left lobe. That's your landmark. Okay, everybody see that?
Yes.
Good. Alright. Sometimes for that left lobe, if it extends way over into the left upper quadrant, because some of them will, you have to make that adjustment. So you may have to come further this way, or come further down, or make your angle a lot sharper, okay? To make sure that you're seeing all of that. And the best way a lot of times is in trans. You'll actually see how far over that lobe is gonna go. So when you're in long and you're seeing it dip like this, because it's heading that way, don't leave your depth here. Make sure you're showing me all of that liver, that whole edge of it, okay? Any questions on the left lobe? Anything you want to add? Am I missing anything? What was that?
You started revealing.
Please see the recording that I will be posting on Teams. Alright, so when we talk about doing the right lobe, we're going to be doing two different approaches, and you will be required to take these images in both places, intercostally and subcostally. Subcostally means what?
In between
Subcostally,
Underneath the ribs.
under the ribs. Intercostally,
Between the
between
ribs.
the ribs. So, whichever one you want to do first, I don't care. I don't have a preference. But make sure you're labeling it IC or SC. One of those. Subcostal and intercostal, so that we know that's what you're intending to take that picture of in that plane, okay? So for me, I always start kind of lateral on the body here. Make sure you have enough gel if you have a much thinner patient and you're riding on those ribs, because otherwise you're going to be losing contact. So right away I can see I'm kind of at medial right lobe. there's the main portal vein coming in here. So intercostally, just as much as subcostally, it is very important to take a deep breath. Alright, so now what I'm doing is just fanning out. Again, not really sliding all that much. I'm finding a good window and I'm fanning out because I'm still in between her ribs. All of these little shadows coming down here, those are her ribs, okay? So intercostally, I have to find a space where I can fan out and get that breathe. So you're placing the membrane of your probe, the face of your probe, in between the ribs. So if these were the ribs, you're gonna place it in there and you're gonna kind of angle like that until you can see all you can see. And then you're gonna move to the next rib space and angle and see what you can see and get your landmarks and so on, all the way down the rib cage until you've seen superior to inferior and lateral to medial. Does that make sense to everybody?
Mm-hmm.
It's easier if you can find that space instead of having to do this over the ribs. It's also not pleasant for your patient. So find the rib space, angle between the ribs, go to the next space, angle between the ribs. You're gonna get more visualization of the liver that way, because see, that's her rib and that's her rib. This is lateral, past all vasculature. There's a little kidney in there, but there's no blood vessels here. Deep breath. So again, we see her ribs, and I'm angling out. That big shadow is in my way, so I slid down another rib and angled out again. Breathe. So that first picture, I represented this edge, okay? This picture shows me all of that part because I couldn't get that in that image nice and clear all together. So there will be multiple images in the same plane sometimes because you're trying to get around the shadows and show every bit of it. So you may have 2 laterals, 2 or 3 mids, 1 or 2 medials. Like, it's expected if you're trying to represent. If her liver was enlarged, it's going to take up a lot more of my screen. So I'm going to have to move in a lot of different ways to show all the different parts of it. A few more pictures are required. Does that make sense? Okay. So her whole lateral lobe here, lateral right lobe, no blood vessels. That's her kidney, by the way. Deep breath. So your mid is going to be with some kidney in it sometimes, depending on how their liver sits. So we're trying to get the longest part of the liver for the length measurement and for our mid. And the mid kidney in the picture is your landmark. Breathe. This is a good example. That's a little bit of her kidney in the picture, but that is not her mid liver. Okay? The way that her organs are oriented in her body, the kidney might be sitting more laterally, so once I get to mid-liver, I'm already past the kidney. I don't see it anymore. So we would like to see some kidney in there, a little bit, but don't try to make the kidney the focus. Make sure you're getting the length of the liver itself when we do this measurement, okay? So we could label this one mid, deep breath. But for her, truly, there's a little liver kidney right there. Breathe. That's her mid. You see how the pictures look a little bit different? Still have actually a little kidney in there. And this measurement, you're gonna get a lot of different, when you get out into the clinical setting, people doing this a little bit differently. We're doing an AP measurement on the liver. It's an anterior posterior measurement. We're calling it the length, but it's an AP measurement. This is AP, right? Well, the liver is sitting this way across the body, not straight up and down. So AP is if you imagined the liver was like this and you've turned it on its side. That's our AP measurement. Okay? Now when you do your measurement also, make sure we're going out to the very edge. Do not include the diaphragm. This echogenic band right here is her diaphragm. It is not part of the liver measurement. So that would be incorrect. That's where your caliper needs to be placed, on the abdominal side of the diaphragm, because everything up here is thoracic. Okay? Everybody see that? Questions? Not yet? Okay, excellent. Deep breath. So when I had that picture, breathe, taking the measurement in mid, that was showing me all the borders that I needed to get that measurement, to get it accurately. But for the mid image of the liver, you didn't see this, right? You couldn't see that margin. I had it cut off because I was just measuring that, this part here, okay? So I took a second picture to show that. Deep breath. And all that is going from here, where I have a shadow and a little bit of contact loss. Now I'm sliding up, here, breathe. Okay, you see what I did? I just slid up into that rib space a little bit so that I can get that shadow out of the way and represent that part of the liver. Deep breath. Another reason when we want to have kidney in our mid picture is we're comparing echotexture of the kidney to the liver. They should be isoechoic, similar echotextures. Okay, if the kidney is darker and or brighter, vice versa, that could point to some sort of pathology. Okay? Typically, if the liver is going to be a lot brighter than the kidney, that's fatty liver disease. Deep breath. Right. So medial, there's our IVC, is going to be just past the IVC. So I'm going to angle through that ribs, sliding up space. Breathe. Here's our IVC. Just push just past it to see the main portal vein. This is the porta hepatis, where all the vasculature is going into the liver. Your CVD, hepatic artery, main portal vein, that's where it all enters. We call that the porta hepatis, or the hilum. That represents medial. That's your landmark. Having the gallbladder in there also can represent medial. Can't see hers in this picture, but it'd be over here. Deep breath. So again, pushing past the IVC, and you may have to kind of twist a little bit, but that's going to be medial. Breathe. This again is where it's coming in. I can see more of my margins here, but this is a medial picture. You see there's like a couple of different ways to represent it. Just make sure you're representing it completely. Small breath in. Breathe. Do you see how those two pictures look a little different? Still representing the medial. Okay? Show me that that vessel is present and I'll believe that you're at the medial right lobe. Okay? What's next? Trans. Oh, I'm going to do subcostal long. Alright. So all those were intercostal. Because I was right up here in her ribs, moving across her ribs this way. So subcostal, you can feel along where the edge of her ribs are. That's going to be your subcostal window. Deep breath. So subcostally, it looks a little bit different, right? I don't particularly care for this approach because it's just always ends up looking more trans to me than anything, but breathe. This would be more like a subcostal lateral picture. I'm seeing this edge here, little bit of blood vessels there, but this would represent a lateral picture subcostally. Deep breath. Yeah, intercostal is just the best way to see your liver. Breathe. Don't see those edges quite as well from this view if I try to come here. That all is going to depend on how high or low the liver is in the body. So if her liver is set a little bit lower, I could probably achieve all of my subcostal images down here, okay? But for her, here is going to be my window subcostally, and I'm angling out that way, just pushing laterally on the patient. Deep breath. So you see how I have to increase my depth, and I'm going to adjust my TGCs. There we go. Breathe. So this is medial, subcostal. There's the gallbladder here. Again, can see all these margins and the hilum where the liver, or where the vessels are going in.
Main lobar fissure, isn't that one of the deals?
Oh yeah. Is it extra credit? Main lobar fissure. Does anybody know what the main lobar fissure is, or like anatomically how to recognize it? No. Cool. So main lobar fissure connects from the gallbladder to the main portal vein, and it's a very echogenic structure, and it's very linear. Might be short, might be long, might be really, really bright, might not be as bright, but that is the main lobar fissure. Okay? Connects from the main portal vein to her gallbladder, which is right here. Does everybody see that?
Yes.
Deep breath. I can skip this. Probably see it best in trans. I had to guess. Breathe. So here it is again, right here. Does everybody see it?
Yes.
That's one of your extra credits. I need to go through and do the other extra credit ones, but. Alright. Deep breath and hold it. When we're doing subcostal mid, it's not where I would want you to take your measurement. Okay? See how that just does not quite look the same? Breathe. There's the kidney. This would technically be representing subcostal mid, but that is not where I want to take my measurement. That is not accurate. Her liver is a couple centimeters larger than that. Okay? So when we're taking our measurements, that's what it needs to look like. This, not, if you can make it look this way subcostal, great, but this is gonna be the most accurate way that you measure that liver, okay? With it, do you see how different that looks from the other image we were looking at?
And you'll notice sometimes certain pictures you're gonna get better intercostally and some you'll get better subcostally, and that's why we want y'all to get all of them both ways, because you're learning those windows.
Yeah.
But once you learn them, like when you get to your abdomen complete, you know, you're gonna know your liver measurement is better, you know, intercostally, so you're gonna take it there. You won't have to take that picture subcostally. But for the liver purposes, the liver test, we want you to take them both ways. So you learn those windows.
Right, last thing is transverse liver. So I like to start with subcostal transverse liver. Just think it's a little bit of an easier approach. So again, you're kind of following along her rib cage here. And then our first picture is the dome picture. The dome of her liver is here. So to see it, I need to angle towards it, right? Here sometimes you can. I start here and work my way around the ribs to see what I can see. When I'm getting inferior subcostally, it's gonna be better over here because that's where the inferior portion of her liver is. Make sense? Okay. Deep breath. So there is gonna be some pressure when you do this. It's a scooping action. So I'm pushing under her ribs and superiorly breathe. It's not crazy comfortable, but it's doable. That wasn't painful.
Really, was it you were trying to do it and I couldn't get past your hand? Was it-
Yeah.
Oh,
I was like, you're gonna have to let me do it and just watch.
right. Yeah, it's hard to show somebody how to do the dome like by holding their hand, because your position sometimes even like this when you're holding your probe, okay? But this is the dome image. There's no vasculature and I can see all of these margins here. Deep breath. So if you really have to push, this approach, the way you hold your probe that way, can be helpful. So you can get some good leverage and push under the ribs. Now as you twist, breathe. Do you saw how I pulled more of that into my image just by twisting a little bit? Okay, so that's what's gonna show me all of those margins was I found where I needed to be and I just adjusted ever so slightly to show all of those edges. Okay? Good on that one? Is that a superior down past the measurement? Cool. Alright. Oh, that's so not sag anymore. There we go. Alright, mid with the hepatic veins. Deep breath. So as you go up, and when they take in that breath, it's good to kind of like angle as they're taking that breath in. So you're already in the spot right as she takes in that breath. And then you're gonna just angle down. I gotta change this, this doesn't work like that anymore. So here, I would take this picture. See all the hepatic's coming in right here? And then this here shows me that much more breathe of the liver here, okay? You saw how I kind of just pieced that together? One edge here, then show the other edge. I'm gonna show you the hepatics. Deep So these vessels here are her hepatics. Let me get it better. There we go. Y'all see that?
Mm-hmm.
If I put color on it, you'll be able to see it. See there? They're coming off the IVC. So that's your mid landmark. You can come here, depending on where their liver sits, and get it, but I don't see it as well. So this is where I'm gonna get hers at. Breathe. So this would be a mid picture. You wanna see those hepatics. I like to see all three of them, but I think if I go intercostally, I'll probably see her hepatics a little bit better. But that's a mid landmark. Again, showing all of my margins. Deep breath. The next mid is going to be your portal vein. So you have two mid pictures already. This is the portal vein right here. Everybody see it? Okay. So that is going to be a mid picture, and then we're going to just keep angling down and decrease your depth for that inferior picture. Breathe. So this is inferior. It's going to show a little bit of kidney, and we're past all the vasculature. That is her gallbladder. You will likely see that in the inferior picture on some people. Alright, so that's subcostal. Intercostal, you're gonna need a lot of gel. Intercostal.
Gel is your friend. What is gel?
It's our friend.
magical.
It's magic. It reminds me of that song. So a lot of the times, if you just put a little bit of gel on this edge and this edge of your probe, you're gonna keep contact. The biggest thing about doing intercostal is keeping contact, especially when you're doing like 85-year-old little Meemaw who's 85 pounds, you know, and she's nothing but ribs and skin, and you gotta try not to crack her ribs as you're running over them. So the gel helps to keep contact, okay? Here is where you're gonna see your contact loss. That's contact loss. So if I get up on a rib and do that, that's contact loss, okay? So we need to make sure we keep the gel there. Deep breath. So for her dome picture, in this rib space, when she took that deep breath, I can't see the dome. So I'm gonna scoot up a space until I can. Now, scooting up a space and angling up in the space. See how I'm twisting it all around to find where I can get in and see, breathe, the dome. These are rib shadows. You're gonna be piecing together your liver images when you're doing intercostal, because I can't see any pathology here. I can see it here in the non-shadowed segments, but not here and here where I'm getting her ribs coming in, okay? Deep breath. So in order to do that, it's sliding over, see look, twisting, angling. So I'm gonna take that picture, I'm gonna take that picture, okay? Do you see how I did that? Those are my domes. Then I come down, and this is where you can see her hepatic vessels coming in right here, okay? Then there's the main portal vein, and I'm just angling down in the same rib space. Now I slid down a rib space, breathe. Do you see how that changed? So I found the space, angled up and down in the space. Can't see any further once you angle down because the shadow, then scoot down that rib space and angle back up, image that, and keep moving down the ribs until you've seen all of it. Does everybody understand how that works? Yes, makes sense? We're just going in between those spaces, angling up and down, move to the next space, angle up and down, so you're gonna see all of those parts of the liver. And your inferior landmarks, same with the kidney in there. This is contact loss. So that means at some point I'm gonna need to put a little bit more gel just on the edges here. And this is where the evolution of your training comes in. You know where you were at to see what you needed to see, but now we have to put more gel on. And now you're going, okay, crap, now I have to find it again. Try to remember your muscle memory where you were on her body. So when you put the probe down, deep breath, you're right back in that spot, okay? Now all you have to do is angle. And that's all the way through the liver. If I move back up through her rib spaces and twist, look at that. I just twisted, breathe. And what I did was I put that sound beam in between her rib spaces so that those shadows were not a problem anymore. Okay? So it's up and down, twisting. All of this is going to adapt you to, what's the word I'm looking for? To be adaptable to all different patients, I guess, is what I'm trying to say. Like, every patient's going to have their liver and everything in a different location. patient. It's gonna sit different, it's gonna look different. They're gonna be able to take different levels of deep breaths. Some people won't be able to take a deep breath at all. So your pictures are gonna be intercostal pictures, and it's gonna be a lot of just piecing it together. So knowing all the different techniques to visualize it will help you when you have those difficult patients. Does anybody have any questions? No, okay. I did not do the main portal vein. That one, I'm gonna do the main portal vein real quick. Forgot about that. So the main portal vein, you have to, you won't need another towel. Just right here will be fine. Alright, so the main portal vein is in your medial view. Right here, that's the main portal vein. So you need to do a 2D, a color, and a pulse wave. And just like your aorta pictures, deep breath. Just like your aorta pictures, what we're trying to prove here is that there is no, breathe, there's no thrombus in there. So we don't want to darken too much, but don't let that be full of echoes, okay? So that's going to be your main portal vein. We're not measuring it, are they?
No.
Okay. Deep breath. See too how I didn't move my probe in between doing my computer adjustments and having her take a breath. So I never moved out of my spot because I know that's exactly where I'm going to visualize it when she takes in that deep breath. Breathe. So this is what I need to see for the main portal picture. All of that color filling the vessel going up and into the liver. Okay, I don't want to see it cut off just right here. I want to see extrahepatic into intrahepatic. Okay? So 2D picture, color picture, deep breath. Your pulse wave picture. I want you to take it right as it's crossing into the hilum. Breathe. Okay? So not up here in the liver. I want it to be right as it's coming into the hilum here. So normal main portal vein flow is what? Does anybody know? No. Okay. There's hepatopedal and hepatofugal. Have y'all heard,
Yes.
learned about that
He
yet?
came and told us those words.
Got it. We've heard those words. Those words have been said
They
to
have
us.
been inserted.
What do they mean? Okay, so does anybody know what hepatopedal means?
It means going
Towards
over.
the liver. Into the liver?
Oh yeah, no.
Into the liver.
Yeah.
So we want the main portal vein to be hepatopedal flow. Going forward. Antegrade is another term. Going into the liver because that is supplying the liver. So antegrade is above our baseline. That's what we need to see. Typically the main portal vein velocity, because it's a vein, you're not having these peaks and valleys and peaks and diastoles. So it's just this constant. It asks for the, no, there's no measurements. Why are those there? Go away.
This machine, they always pop up.
I don't like it. Okay, go away. You don't have to measure it. Goodness. If calipers pop up on your screen when you're doing the measurement or the pulse wave for it, just do what I'm doing and move them to the baseline where they both stay 0.
They
Okay.
won't clear off all the way on them?
Hmm?
They won't clear off?
No, they won't. They
We'll
won't
see
go
if we
away.
can go, I'll see if I can go.
That's weird. So, but you'll notice too this velocity here, typically between about 15, 20, upwards into like 35, 40, depending on the condition of the liver. But we want hepatopedal flow. What's hepatofugal flow?
Out of the liver.
Away. I remembered it because you pedal towards something, and fugal is like fugitives run away. So that's how I always remembered it. But that's what we needed to look like for the main portal vein. And I think that's it. Extra credits. I showed you main lobar fissure, just ligamentum teres. Have we showed y'all ligamentum teres yet? What is the ligamentum teres?
The ligament in between.
It comes off the falciform ligament at the very end, but
Deep breath. Breathe. This is hers right here. Some are gonna be very, very, very bright. Very echogenic. It's gonna stand out to you. I actually had a radiologist one time ask me if it was a hepatic lesion that I didn't document, and I said, no sir, that's the ligamentum teres. So, that's what that is, don't freak out. Hers isn't as echogenic, some of y'all's may be really bright, but that's gonna be your extra credit picture right there, and you would just label that ligamentum teres. Showed you the main lobar fissure and ligamentum venosum. Deep breath.
Y'all better know what that ligamentum venosum is.
I'm like, don't hate me, I haven't actually ever specifically taken a picture of the ligamentum venosum. Am I tripping? It separates the cauda.
You've
right?
taken
Mhm.
hundreds and thousands of pictures of
I
that.
have, but not like specifically. Thank you, Marcus, for not making that obvious. The question that I asked in case anybody. Oh no, it's on video. Instructor was questioning herself. Ligamentum venosum separates the left lobe from the caudate lobe, so that's going to be it right there. So while you're at it, take in your left lobe medial / caudate. If you got a good image of it, just slap on your ligamentum venosum label. Get your extra credit points. Keep moving. Or are we making them do it at the end?
Can you do all
I think they
three
have to go
together?
back and do that.
What's that?
I think they have to go back and do that.
Okay, I wasn't. Then scratch what I said. Extra credit pictures have to be taken after all of your other pictures are done. Apparently.
Well, just because we don't want you, I don't.
No, I don't want them getting distracted,
Yeah.
like trying to get extra credit when they haven't gotten their main.
Yes.
That's later when you guys are a little bit more, methodical in your
No,
standing.
I just want you to make sure. you
I want to get all their pictures. Yeah, you're right.
And I just need to borrow Michelle a more.
You can go ahead and